Hi, this is Conrad Fisher. I'm an Associate Professor of Physiology and Associate Professor of Pharmacology at Touro College of Medicine in New York City. Welcome to Gastrointestinal Physiology for Kaplan Medical. This is a very important subject, highly tested and highly interesting. Who doesn't love to eat? And I am going to be keeping in mind the fact that as a residency program director, what you learn today in these slides has enormous implication for your future. You have to keep in mind that not only is it good for patients, not only is it only good for your soul, it's also good so you can get the residency that you want. I look forward to seeing you into the future when you're applying through ERAS. I look forward to meeting you, and I look forward to your success. The first part is to take a look at the basics of the anatomy of the gastrointestinal system. Now, no matter what it may seem to you when you look at this picture, what is the single largest constituent of the gastrointestinal tract? Is it serosa? Is it epithelial cells? Is it glands? Is it muscles? Is it nerves? The single largest component of the gastrointestinal system is muscle. The gastrointestinal system is a long muscular tube. It's a long muscular tube that moves. It's got circular muscles that make it go squish, squish, squish. It's got longitudinal muscles on the outside that make it go and it's like a cannoli or a burrito that moves. Now, in between all these muscles layers, we also have nerves, a myenteric plexus, a submucosal plexus. And on the inside, we have glands. However, the predominant constituent of the gastrointestinal system is muscles. And the major effect on those muscles is acetylcholine. In the mucosa, the epithelium is a single layer of specialized cells. Now, those cells can be secreting hormones. It can make secretions that are exocrine in nature, and sometimes remember that hormone release by definition means that it is going into the bloodstream. The lamina propria is a layer of connective tissue, and it basically holds everything together. So the lamina propria is not really referring to one particular type of cell. It's basically looking at the matrix that holds all the other cells together. And the muscularis mucosa is a thin layer of muscle, and basically, how do you change the surface area? The muscularis mucosa is how the body in the bowel changes the surface area of those bowels, because remember that you can have an enormous shrinking or an enormous expansion of surface area based on what the body needs, and does this by either contracting or relaxing the muscularis mucosa. The submucosa is a layer of connective tissue, and in it you have large blood vessels, glands, lymphatics. The lymphatics, such as the lacteals, is where the fat goes in. So the lymphatics of the submucosa of the GI tract is basically the major absorptive surface for chylomicrons. Now, the GI tract can't absorb triglycerides as a whole. They're much too large. They have to be split by what enzyme? By lipase. Lipase splits those triglycerides into two free fatty acids and a position 2 monoglyceride. Two free fatty acids and a position 2 monoglyceride, would you have a fatty acid on position 2? It's kind of like making change of a $20 bill. You get a $10 bill and 2 fives. And then it gets absorbed into the lymphatics. The lymphatics like a big catcher's mitt. And the ball's away, and caught into the lymphatics and re-esterified into chylomicrons. The lymphatics are enormous in their size. They are colossally large. Meissner's plexus. Don't you wish you were Meissner? You could have gotten your name on a plexus of vessels inside people's butts. Wouldn't that be very interesting? And these are a set of nerves that are located in the outside, and it tells you that you have a brain inside that gut. Do you know that the SSRI medications like Paxil and Zoloft and Prozac, the SSRIs really were describing a neurotransmitter that was first found in the bowel? Isn't that interesting? We have gastrointestinal peptides in our head. And serotonin is one of the major neurotransmitters in the gut, one of the major neurotransmitters in Meissner's plexus. This is part of the enteric nervous system that's involved in the secretory activity. Now, enteric nervous system means in the GI tract. Your guts have brains. Now, there's an inner layer that's a circular muscle layer. There's an outer layer that's longitudinal. Which of these things do you think is responsible for peristalsis, the moving forward of stool? Which is responsible for peristalsis? Longitudinal muscle. Longitudinal muscle moves the bowels forward, moves the contents forward. The circular muscle on the inside layer is responsible for the mixing contractions. The longitudinal muscle is responsible for the peristaltic or mass movements. Both of them are important. Next question. Which part of the GI tract has the largest amount of muscle? It's the stomach. The stomach is the only place that has 3 layers. What do you see extra in the stomach? You get an extra one called the oblique layer, because your stomach is mixing and churning and moving and mixing and moving and churning and burping, and that's the stomach. Now, we have a myenteric nerve plexus that's in between them, that's located between the muscle layers. Did you know that there's an SA node of your bowels? There is. The stomach moves at 3 times per minute. There's an SA node. The intrinsic basic electrical rhythm of the stomach is 3 times per minute. The serosa is the outermost layer of the GI tract. It's basically like the pantalones de sus colones. It's the pants for your colon. There's an outer serosal layer, and this has enormous significance because it also means that when you have a disease like colon cancer, if we were to mix in some pathology here, as long as your malignancy is not outside your serosa, you can fix it, you can cure it, you can resect it. So the serosa is an outside connective tissue layer that protects the organ. Now, those connective tissue and epithelial cells do have some autonomic fibers that are synapse and nearby target cells in the enteric plexus, so it does have some communication ability. But the serosa is mostly an outer connective tissue layer that's really like putting on pants or a coat on top of your undergarments. What form of control controls the nervous system of the bowel? The sympathetic situation is not as important, in fact, as acetylcholine. Now, generally speaking, the synaptic junction at the end of a nerve fiber secretes norepinephrine, but that's not specific to the bowel. That's true pretty much everywhere in the sympathetic nervous system. Now, which do you think moment to moment has greater effect? Sympathetic or parasympathetic of the bowel? Well, it's actually parasympathetic. Parasympathetic with acetylcholine is the main thing that controls it. However, sympathetic slows it down. And what ends up happening with the norepinephrine is it slows down motility, it slows down secretions. Because when it's time for you to run away from dinosaurs so you don't get killed, it's the wrong time to stop to have a poop. But it's time to run away. Also, when you need the energy to be able to put it to your muscles, to be able to give them the energy they need to disappear, it's the wrong time to say, sit down, eat, relax. The sympathetic nervous system slows motility and decreases secretion in order to save that energy for running away. So, sympathetic stimulation relaxes the bowel wall. That's hard for some people to understand. What do you mean it relaxes it? Doesn't that mean that it helps it, get better? Well, no, relaxing the bowel means no muscular contraction. There's no muscular contraction, nothing moves forward. See, the bowel, we said, is a long muscular tube. So in order for it to move forward, you've got to have muscles contracting to have things move forward. And an increase in sympathetic stimulation increases constriction of secretion. So it doesn't only slow the bowel muscle, it slows the secretions, tightens the sphincters, and in general, increase in sympathetic activity slows all these processes. Sympathetic slows the gut so you can dilate the gut so that you can use the energy for your eyes, your muscles, your heart. The most important stimulation is parasympathetic. Now, if you see people using the words parasympathetic, vagal, and acetylcholine interchangeably, it's because parasympathetic, vagal, and acetylcholine are interchangeable. Acetylcholine increases secretions, increases motility. Vasoactive intestinal peptide, which is VIP, causes you to decrease the constriction of sphincters. That means stool and the GI contents moves forward if you open the sphincters. Vasoactive intestinal peptide not only increases the activity of bowel constrictions, it also opens those sphincters, so it's kind of like opening up the watertight doors on a submarine. Helps everything go forward. GRP is gastrin-releasing peptide. Gastrin-releasing peptide increases gastrin and therefore will increase GI motility as well. An increase in parasympathetic activity makes you dilate your bowels so that you can open them up in terms of opening the sphincters. And parasympathetic stimulation makes your bowels move more often. Acetylcholine makes your gut secrete. Vasoactive intestinal peptide, when it says inhibitory, it's inhibitory on sphincters. And inhibition of sphincters helps stool move forward. Gastrin-releasing peptide stimulates the release of gastrin. What a nice name, right? Gastrin-releasing peptide. I think the release is gastrin. Yes, that's true. Gastrin-releasing peptide makes you release gastrin. Yes, it does. Well, gastrin-releasing peptide is also why it is that when you give atropine, you can't slow down bowels too much. You can't slow down acid secretions more precise. You can't slow down acid secretion. Atropine has been known since the 15th century as belladonna. It was known in medieval times that it would dilate the eyes of people, thought to make you look more beautiful. However, why doesn't it stop acid secretion from the guts if you're blocking acetylcholine? Well, atropine doesn't block all acetylcholine, and it doesn't block the part that is from gastrin-releasing peptide. The vagal stimulation increases gastrin-releasing peptide, and gastrin-releasing peptide is not based on acetylcholine. It's its own independent neurotransmitter. This table, which looks like just an ordinary table like any other, like the rose bush in The Little Prince. Yesterday, this hormone was just another hormone on the table. Now this hormone has become special to me in all the world, like Little Prince and the flowers. Well, we have to take a look at this table and say, well, what questions come out of this? We can go the usual ordinary way and say, secretin is stimulated by acid. Acid makes the secretin. Secretin makes the bicarb flow. Fat stimulates cholecystokinin. Cholecystokinin constricts the gallbladder. The gallbladder releases bile. The bile absorbs the fat. Well, it's not very interesting, is it? Read the table. What do you need us for? You need us to be able to say, what questions are you going to get out of this? Do you know that only one of these has feedback inhibition? Which is the only one that has feedback inhibition? It's gastrin. Gastrin's the only one with feedback inhibition because the stomach acid inhibits gastrin. Which of these is the only one that has neural stimulation? Do you know that the only one that actually has neural stimulation is gastrin? Acetylcholine and vagus stimulation make the gastrin? Did you know that only one of these is found in both the stomach and the duodenum? Why, it's gastrin. Gastrin's the only one found in both the stomach and the duodenum. Did you know only one of these is stimulated by fats? Cholecystokinin is the only one stimulated by fats. Only one of these is stimulated by acid, secretin. So acid makes the secretin. Secretin makes the bicarb. Bicarb neutralizes the acid. Acid makes the secretin. Secretin makes the bicarb. Bicarb neutralizes the acid. So you could say that acid stops acid. Yes, it's true. Acid stops acid. Now, not only does it stimulate bicarb flow out of the pancreas, it also stimulates bicarbonate production in the liver as well. Secretin was the first hormone ever described, 1908. Yes, endocrine hormones is only just a little over 100 years old, but is the first one ever described. Acid touches the duodenum. The duodenum makes secretin. Secretin stops acid. Now, secretin does it both ways, by neutralizing the acid that's made from bicarbonate coming out of the pancreas and by inhibiting G cells. When secretin inhibits G cells, it also stops the production of acid. Wow. Fat touches duodenum. Duodenum makes CCK. The CCK releases fat from the gallbladder and opens the sphincter of Oddi. Why contract the sphincter of Oddi if you're not going to open? Why have it that you want the bile to come out if you're not going to open the sphincter and let it come out of the gallbladder? It will contract the gallbladder and open the sphincter of Oddi the same way it's good to be able to open the garage door if you're going to take the car out. You know what I mean? Gastrin is the only one that's both in the duodenum and the stomach. Acid is produced by gastrin. So let's say that. Secretin is stimulated by acid. Gastrin stimulates acid. Acid makes secretin, but gastrin makes acid. Acid makes secretin, but gastrin makes acid. Acid makes secretin, but gastrin makes acid. And also gastrin is the only one that slows GI motility. It's the only one that actually will make it that the stomach will grow, and gastrin will make that bowel contract, and gastrin puts you in gastric growth. So it'll grow the G cells, it'll grow the lining of the bowel. GIP and GLP are long names. It used to be called gastric inhibitory peptide, now sometimes known as glucose insulinotropic peptide. What a pain in the ass. It means these are also called incretins. GIP and GLP are extremely important hormones from the point of view of endocrine physiology. In endocrine physiology, when we're treating diabetes, the incretin drugs like sitagliptin, saxagliptin, linagliptin, sitagliptin, saxagliptin, linagliptin, these are ways of blocking the metabolism of the hormones that make your pancreas absorb food. In other words, incretins are another name for GIP and GLP. GIP and GLP come out of the duodenum. The incretins make your pancreas secrete insulin and decrease the glucagon. And this is the mechanism of action of the diabetes medications known as sitagliptin, saxagliptin, linagliptin, which block the metabolism of the incretins. This is a must-know subject for your Step 1 exam because so many indications for diabetes run through incretins.